Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Okay. Hi, everyone. Welcome back to the Breast Cancer Podcast. Today, we're going to be talking with the two breast surgeons.
That's
Jennifer, that's us.
Jennifer,
Is
author.
going to ask Jennifer, the author of Don't Wait,
Don't wait.
is going to be asking us questions. So
Amazon, it's on Amazon.com.
the link is on Amazon. Don't wait. And so, Jennifer, don't wait. Go ahead and ask your questions.
So what is two is better than one breast surgeon model?
That's great. Dr. Halaharvi,
Yeah.
this is your topic.
Yeah. So, two is better than one breast surgeon model is where two surgeons perform a double mastectomy or a bilateral mastectomy together. And we performed over 1,000 mastectomies. We've been together for the last 10 years or so doing the surgeries on women. And what we found in our own practice is that it does cut down on time under anesthesia. It's cost effective for the patients. And Dr. Cripe trained me in my residency and fellowship. We operate pretty identically to each other.
And that really started one of the risks of surgery is the longer the time, the increased risk of infection. And when doing surgery with plastic surgeons, if one surgeon's doing both sides, it's going to take longer.
Yeah.
And then the plastic surgeon has to come in. So that's kind of how it started, that we said, hey, let's do surgeries together. Now with the aesthetic flat closure that we're doing, it takes additional time to remove some redundant tissue sometime. And so if we're trying to take this extra time to remove redundant tissue, and then you have to go to the other side, there's time or infection, there's cost. There's also physician fatigue. So hard to kind of measure that a little bit. But when you have two surgeons, I guess the last thing I think that's important is you can look over to the other side and say, hey, what are you doing? How are you managing that? And so if there's little tips or tricks, you're cutting down that learning time. So I think you're both getting better and better faster. And then Dr. Halaharvi wanted to really objectively review it. So there's a paper that you're putting together right now, right?
Yeah. So we are both fellowship trained breast surgeons, but we also train a fellow who is breast surgery fellow is someone who's completed general surgery for 5 years after medical school and then is here for an additional year of training to be a breast surgeon. So we both train breast fellows, and Dr. Cripe has trained a number of them. And the most recent fellow has worked on a paper looking at about around 500 women who had double mastectomies, and where we worked together, and she compared it to when we did surgeries by ourselves. She noted that the time under anesthesia for the patient is significantly lower, as well as the cost for the patient, which is, I think, is a great thing. So
very good. So what types of surgeries do you perform together?
Anytime we're doing kind of both sides, I think we try to. We think of mastectomies, but then there's not just one mastectomy. Now there's a whole bunch of different mastectomies, from simple mastectomy, total mastectomy, modified radical, nipple sparing, aesthetic flat closure,
preservation, sensation preserving mastectomies, and then Goldilocks.
And sometimes kind of leading up to the mastectomy. So for the nipple sparing, where we're trying to keep the nipple, a few of the plastic surgeons will want us to go in a few weeks before and try to disconnect part of the blood supply. So we call a nipple delay procedure. And if we're in the same institution, then again, having somebody else come in and do that, especially if we're going to be operating on that person 2 weeks later. It's nice that we've already done that nipple delay procedure. So we'll do that
Yeah.
together.
Yeah. Even lumpectomies we perform
Right,
together if someone needs a lumpectomy on
on
both
both
sides.
sides.
Yeah. It does just cut down time and anesthesia. And
Yeah.
we are constantly learning from each other, which I think is great.
That's
Yeah.
good.
Yeah.
It's very helpful for the
Yeah.
patient.
Yeah.
Yes.
In your experience, what do you think patients want?
Go ahead.
I mean, my thought would be patients want a good outcome. So I think
Mhm.
that's something that I would want. So I always want a good outcome. I think patients want someone's going to listen to them and not just be paternalistic and tell them what they need to do. And for some people, that's what they want is just, doc, tell me what to do. Okay, great, we can. But really to have someone listen to them and then again, sometimes try to tease out of them what they want because they may not know. So that's something that I want to do is make sure that when we're talking to patients, we're not just telling them what we want them to do, but really trying to go through the pros and cons. And I even had a patient that came in the other day who wants a bilateral mastectomy. She's at high risk and she was ready for a battle, thinking that potentially I,
Yeah.
as the surgeon, wouldn't want to do that for her. So she was
Yeah.
ready to battle. I said, I need to tell you the risks and benefits both ways of high risk screening versus
Yeah.
surgery. And she's like, I want the surgery, and I was like, okay, but I need to counsel you both ways. So
Yeah.
I want to listen to the patient, but I also want to counsel them.
Yeah.
Mhm.
How I see what patients want is when they get told that they have breast cancer, their world is just shattered. So I see two types of people. One person comes in, just take them off right now. Just, I'm done with it. I don't need it. But then we still have to go through the procedure of like what Dr. Cripe said, explaining the risks. And it's our job to make sure they're understanding and they're just not making like an emotional decision. The other person comes in, they're very stoic. They listen to everything. They go through and they're not, feeling things or have not gone through or the diagnosis has not hit them yet, but then down the road then they can experience things like, oh my gosh, I was diagnosed with cancer, I went through surgery, I went through all these treatments. So
Mhm.
patients sometimes may or may not know what they want. What Dr. Cripe said, figuring out what patients want, where they are in their life, what's important to them, talking to them, listening to them. One thing I think is really great is not just he's empathetic and compassionate and use a sense of humor, but also you do use
Do
sense of
I?
humor,
Okay.
yes.
Yeah.
And I think all those things are so important in that scary situation for the patient, but also finding out what they want. But also, we both talk about this all the time in surgery as we are teaching residents and fellows is these are the scars that patients live with for the rest of their lives. It's a
Mhm.
reminder for them that they've had cancer. So we're going to try to make it the best possible for what we're given at that time. So
What is the role of a breast surgical oncologist in a woman who is newly diagnosed with breast cancer?
That role is different, different places, probably. Yeah.
yeah, so as a breast surgeon, we call ourselves the first responders to the woman who's just been told that she has cancer. So to helping them to get through that, telling them that you have cancer, and also we help them whether they need surgery first or send them to medical oncology if they need chemo first or radiation oncology to have this discussion what radiation is entailed. And so our job is, I call as captain of the ship. I have a patient who calls me, captain every time she
Mhm.
sees me, which I think it's funny, but it's true. We are the people that are actually taking care of them and helping them to go through the referring physician to the physicians who are going to be taking care of them, whether they need chemo, radiation down the road.
And at least where we're at, we're the gatekeepers.
Right.
So people come to see us first after an abnormal mammogram before the biopsy. I'd say that's unusual.
I was
Most,
surprised.
yeah, most places
Yeah.
across the country, that's going to be done by someone else, either radiology, your primary care physician's going to be ordering all of that. And then once there's a diagnosis, oftentimes then you see the surgeon. Sometimes after diagnosis, different places you'll go see the medical oncologist might be the person that's helping to organize kind of what happens next. But in Ohio Health, where we're at in Ohio, we like to see the person first because sometimes you like we had talked about, if we are very highly suspicious that it's a cancer, I might tell you, okay, even if your biopsy is benign, I wouldn't trust that and we would expect surgery. So we're looking for an abnormality within when the biopsy doesn't make sense. We call it discordant finding that we'd still go to surgery. And if you're not seeing a surgeon first, they may not know that. Also, if you get an abnormal biopsy, we're the ones that help figure out, do you need risk reduction? Do you need surgery? So if you're just coming to see the surgeon once you have cancer, I think you're probably missing out on a lot of people that would have additional benefits. So that's the way we do things here. So we are the gatekeeper, we're the
Yeah.
captain of the ship,
Yeah.
but different places across the country or the world, that's going to probably be very different.
Yeah.
And who is a candidate for Goldilocks?
Yeah, so Goldilocks is a procedure where we both perform the mastectomies together on this person who wants a double mastectomy, and it's a for a woman who has really large breast and drooping breast, and after we nurse babies and things like that, sometimes breast can be really drooping. So large drooping breasts are actually really good candidates, and it just so happens those patients are not really good candidates for traditional reconstruction, whether using implant-based reconstruction or sometimes using the autologous are using their own tissue to create a breast mound. These women typically tend to be higher BMI, and locally, our plastic surgeons don't like to operate on women over 37, 38 BMI. So,
Okay. And why do they call it Goldilocks?
yeah. So Goldilocks, it's a storybook, the fairy tale where Goldilocks gets lost in forest and uh, tastes porridge, which is too hot. The next
Too
is
hot,
too
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 cold.
hot, too cold, and then there is, it's
Just
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 right.
right.
So Goldilocks is just right procedure. It's not traditional reconstruction. It's not flat closure. It's something we use their own skin to give them a breast mount. So
And is the Goldilocks mastectomy a breast reconstruction?
yes, it is. It's a type
Yeah.
of breast
Okay.
reconstruction. Yeah.
just
So
using
is
the skin
just
instead of,
using the
yeah.
skin instead of using like tissue expanders or implants, just as aesthetic flat closure is type of breast reconstruction as well.
Okay.
I don't know if you knew that or not, but
I did not know.
yeah.
I learned something new.
Mhm.
Who is the ideal candidate for Goldilocks?
It's that person who has really large breasts, is a smoker, larger BMI, diabetic. These are patients typically not a candidate for traditional reconstruction, would be candidates for Goldilocks mastectomy. But the best outcome is really on those women who have really large breasts.
And is it safe from an oncology perspective?
Yeah, we perform mastectomy the same way as we would if it's a total mastectomy or skin sparing mastectomy. We remove 90 to 95% of the breast tissue. So you cannot remove 100% of the breast tissue when you perform a mastectomy, but mastectomy is performed the same way that we would do for the other
And I'd
mastectomies.
say also how Dr. Hala Harvey really brought this back to Columbus, Ohio, because we had a certain number of patients that didn't maybe have great insurance, and some of our plastic surgeons that are private practice wouldn't want to take care of those patients. And when they are a little heavier, which was the BMI that we were talking about, they don't have great options and they have a lot of redundant tissue. And it's like, okay, what can we do for these people? And that's really where Dr. Hala Harvey said, we need to do something. We need to
Mhm.
advocate for these patients.
Yeah.
And if the plastic surgeons or the hospital or no one else is going to do it, she's like, I'm going to do it. And so went out and learned this new technique and brought it back to say, okay, we still have a way that we can do reconstruction for patients. Sometimes it's a bridge. So if they're losing weight, make sure the cancer treatment's over. And then they have this Goldilocks, they have an A to B cup mound, and then they might go get an implant later once all the treatment's done and the plastic surgeons feel potentially better, kind of lower risk, lower complication impact on their cancer treatment. So sometimes it's a bridge, but then sometimes they're happy just to have an A to B cup, especially if they're larger. Most of those women would like a reduction. They'd like to be smaller. They can't exercise, they can't do things, and so they're most of the people have been really, really happy with
Good.
having a smaller breast mound.
Yeah.
But it's been a great addition to what we have
Yeah.
to offer patients.
Yeah, I feel very lucky to do it with Dr. Cripe. It's very unusual for two breast surgeons to be performing this type of procedure across the country. Most common thing that happens if a breast surgeon is performing the procedure is they work with plastic surgery.
Right.
Okay.
And so they do the reconstruction, the breast surgeon does the mastectomy, whereas we both do both together. So
And so, what's my next one? How much additional operating room time is involved with this procedure versus the traditional non-reconstruction?
yeah, the traditional mastectomy is usually a couple of hours, and this is usually 4 to 5 hours, depending on how large the breasts are. And we are actually doing it faster and faster we have done almost about 50 cases right now, and majority of the patients are really happy with their outcomes. So.
And what's the difference between the Goldilocks aesthetic flat closure and the VY plasty?
Yeah. So a Goldilocks mastectomy is essentially it's just right procedure where you're not using the tissue expanders or using your belly tissue to create a breast mount. And aesthetic flat closure is where we remove the breast tissue and remove the tissue on the sides, and so we perform this contouring of the chest wall, so there's not that excess tissue. The VY helps with the aesthetic flat closure, where we remove that tissue on the side. So when you're looking at the incisions, actually looks like a V.
And if you look in the old days, when the surgeons would do a
Oh yeah.
mastectomy, you'd have still the ridge maybe at the bottom. You'd have a lot of lumpy areas on the side. Women sometimes refer to as the side boob.
Mhm.
So when the breast is pulling this side tissue forward, it all works great. When the breast is gone, then this tissue will kind of just fall back into the armpit. And then if you do wear a bra with prosthesis, it'll fold over, it'll get pinched, it kind of hits the arm a little bit. And so one thing that we try to do is thin out that extra tissue that some people have. Not everyone has it, but that's where the aesthetic flat closure comes in, is really trying to look at each person's body type and then trying to make it as flat as we can while also having some redundant tissue that you can raise your arm and it's not too tight.
Right. Yeah.
And that's where we use a VY plasty on the outside, or something called an angel wing is another thing we do, is a couple different techniques to remove that redundant tissue on the outside part of the side.
How is the blood flow to the tissues maintained with the Goldilocks?
So we preserve the skin flaps, and so we make sure the blood flow to the skin flap. It's coming from different directions, from the inside, some on the outside, and what we call 6 o'clock region at the bottom. So we have to preserve those blood vessels for the skin flap to survive. And we do see minor complications with the Goldilocks where there is some tissue breakdown. And we typically tell patients the typical traditional mastectomy without Goldilocks or aesthetic flat closure, it's about 8 weeks, 10 weeks recovery time. Goldilocks is about 12 weeks or so at the minimum. I mean, you're doing a lot of surgery, a lot of mobilization of the skin flaps, and there's fluid that builds up on the inside. So it does take a little bit longer for the healing, but I mean, the outcomes look really great. They look like just had a breast reduction without having the breast tissue.
Okay. And who does the Goldilocks surgeries?
In our institution, we both do it together. In most of the other institutions, the breast surgeon does it with a plastic surgeon.
Plastic surgery. Okay. And then aesthetic flat closure. Do you want to talk about that?
Yeah, aesthetic flat closure is something that when I came out of practice from training, we just called it mastectomy. So we didn't have all the neat names that we do now. And as you talk to patients, one of the things they disliked the most was that outside tissue. And so I just started changing and extending the incision. And then that wasn't perfect. And then we did the VY flap. And so then that's kind of moved into, well, we do angel wing for certain people. Now it really depends on the patient and what type of extra tissue they have. And so I call it the ultimate body art, because we're trying to contour the body, which is not flat and it's going to be round. And we want a little bit of extra tissue, but a lot of different ways. Then we can try to do that contouring, even connecting the tissue in the middle. So lots of times our incisions, when I was taught, they would stop and we don't want to connect in the middle, but then you could have a significant kind of pooch in the middle there, and nobody wants that. So now we'll often connect that incision all the way across, but it adds a little more tightness to it. So it's continuing to evolve, but aesthetic flat closures, now it's got a good name, essentially looking at surgeons that are going to pay extra attention to that body. So when that person's done, that they have a better body image and can, again, wear a bra or
Yeah.
prosthesis, or their clothing is going to fit better, not having too much redundant tissue. And just some surgeons say, okay, I'll just take care of the breast cancer, I don't care about the rest. It's like, well, that's unfortunate. Let's care about the whole person, because you have to live in that body. So it's just paying extra attention to that.
I will say this is all I know in my training is where we performed aesthetic flat closure. I think Dr. Cripe didn't call that, but
Right.
I think a lot of surgeons across the country probably struggle with performing the aesthetic flat closure. It does require a little bit of thinking outside the box. So some surgeons across the country will still employ plastic surgeons to take out that redundant tissue underneath the arm. So it's not uncommon to see a breast surgeon working with plastics, but again, we performed so many double mastectomies together, and we do that essentially because I was diagnosed with breast cancer. I had a double mastectomy 9 years ago, and patients seek us out because patients who've had surgeries from us go out and tell other people. And so that's a lot of our patients come to us from like word of mouth. But I think what Dr. Cripe doesn't know is he was already pretty cool in the breast cancer world. He
Oh
just did
wow!
not
I'll
know
tell my
that.
kids.
Yes, yeah,
Right,
tell
I'll
your
tell my
kids.
kids.
Yeah, but the National Cancer Institute actually coined this term called aesthetic flat closure. And I think it's really important to use that because of what he was saying, removing the tissue underneath the arms. And then there's this ridge of tissue where the abdomen comes into the chest called inframammary fold region. And that we also have to, contour it, or I don't know what the
Yeah,
word you use, the
you kind of
contour it,
thin it
thin it
out,
out a little
yeah,
bit.
and taper it
Oh,
down so that it's not so abrupt of a change.
so
Mhm.
it is very much like being an artist to kind of think through those things. So
Mhm. So I think that's all the questions that you had for me, but I have my own.
yeah,
All right,
go
I'm
ahead.
excited. Bonus round. We got a bonus round here, folks.
So from the form, I mean, I know most of the answers to these, but in the 11 months since my surgery, a lot of these questions have come up from others. And so I thought I would ask so that everybody could hear the answers.
Right.
I've seen where some surgeons do aesthetic flat closure and leave that tissue in between. I think you already answered
Mhm.
why. But I know that you do the one long incision. And is there is it just a cosmetic benefit or?
Yeah, I found it to be more of a cosmetic benefit, and it depends on how much subcutaneous tissue people have. So we don't really think of it that much, but we're all going to have some subcutaneous fat under our skin. And if you have a lot and you have two large breasts really pulling forward, you could have an inch of that tissue. So if you leave that, you'll be concave where the breasts are gone, and then you have a 1 inch kind of middle, we call it a middle nipple almost, because it's a big bump that sticks out in your chest, and nobody wants that.
Yeah.
And so I just started connecting the two. I think it's a little harder from potentially some of the fluid collection, because if you separate both sides, you're going to cut down on that fluid at least crossing over. But I feel that I'm okay with extra fluid for a long life of not having that extra kind of
Yeah.
pooch in the middle.
I've seen patients when you don't take out that tissue, it does pooch out and it causes pain
Yeah.
as you wear like prosthesis and things like that. So
Well, and I can tell you from experience, the
Mm.
seatbelt
yeah,
Right. Yeah.
will. So because it hits you right in that spot.
yeah.
Good point.
So some patients get to stay overnight in the hospital, and others, like me, were outpatient. Can you talk about that?
What do you think is better? Did you prefer going home, Jennifer,
Well,
or
once
not?
I had an issue with the anesthesia
Mhm.
where they hit me with the very last thing they could. Because I think what you had said was if the only reason we would not send you home is if you're having issues with the anesthesia. And I did. And so finally, the last thing that she gave me worked, and I was able to go home. Um, I'm better off going home, I
Mhm.
think,
Mm.
Yep.
because, then you can sleep in your own
Sleep in
chair.
your own bed, share, what yeah. So,
And
back in the
yeah.
day, everybody stayed.
Mhm.
You know, you would hear years and years ago, they might stay 2 to 5 days or something. When I was trained, most patients, I'd say almost every patient stayed overnight. And around, I think 2015, 2018, you start to hear a few reports and papers about same day mastectomy and sending patients home. I just always felt like, well, why not just keep them overnight? It's not a big deal. It's one night and make sure that their pain, nausea is controlled and things like that. But then COVID hit
Yeah.
and we couldn't keep people in the hospital. We had to send them home because COVID was for the sick people that, or the hospitals for the sick COVID patients. And so we started sending everybody home and they felt better. And we were worried about bleeding or
Mhm.
infection and found out it didn't really happen. And then they got to sleep in their own bed or chair and they felt better. And so after COVID, now we've just kind of continued that. I think for me, I think my patients have been very satisfied with that. Dr.
Yeah.
Harvey, what do you?
Yeah, I was actually during COVID because I would keep patients overnight before COVID.
Mhm.
And during COVID, that adoption of sending patients home the same day was very discomforting to me. Like I was very worried.
We don't
I,
like change.
I know.
Mhm.
And then I would give them my number, checking on them, making sure you're okay, and all those things. And it turns out women actually sleep better. Patients actually sleep
Mhm.
better at home in their own beds as opposed to the hospital. And there's a small risk of infection and things like that you could get from the hospital, pneumonia, urinary tract infection things, and then they wake you up every 2 hours to take your vital signs, things like that. So I have found pleasantly surprising is women do well going home than being at the hospital overnight. We will still keep patients overnight if they need to for different reasons.
Or reconstruction. Some of those
Yeah.
patients, when they're using their own what called deep flap, they're taking the belly fat and moving it up to the chest.
Yeah.
Those patients are typically going to stay 3 up to 5 days potentially, but a majority of the patients, even tissue expander patients, often go home same day now.
Yeah.
So post-surgery treatment seems to vary from surgeon to surgeon, from what I've heard from others. Like I got the physical therapy, you'd already set it up. And some of these patients, their physicians aren't talking physical therapy with them at all.
Mm.
And, you know, is that like a normal protocol just to automatically do physical therapy? Or is it up to the patient to say, hey, I can't raise my arms?
Right. It's changing. So
Okay.
nothing stagnant in this world. We didn't used to routinely send patients to physical therapy, and now we are trying to do some prehab. So really for our cancer patients, and it started, I think, even with orthopedics,
Mm.
where they would get patients moving their leg or their knee like they would after surgery is going to be over, so they're ready for it and they're used to it. And then found out that patients did better with prehab, and so now we're doing the same thing for it. Our institution here in Central Ohio is getting our patients evaluated, hopefully before surgery, find out what limitations they have, tell you what stretches you'll do, and then evaluate you around 4 to 6 weeks after surgery. So it's already all set up. Otherwise, historically, there'd have to be a dysfunction or a problem before we'd send you to physical therapy.
Yeah.
And then we had to wait on you, the patient, to tell us. So
Yeah.
again, as the surgeon, if I'm only seeing you at surgery and then 2 weeks later, a lot of these problems aren't going to come up maybe till 4 to 6 weeks, and then we're not going to see you maybe till 3 to 4 months. And so I think it's good to already have that set up so that we don't need to wait until month 4 to find out, oh, now I'm not moving my arm well, and now I need physical therapy. So initiating it sooner, you're going to get back to kind of normal range of motion faster.
Yes, I did.
Good.
Got back on my bike.
Good.
So some patients have plastic surgeons do their closure, their aesthetic flat closure, and after the breast care surgeon finishes. And I know that that wasn't the same for me. Do all surgeons perform that type of surgery? Aesthetic flat are they all trained with aesthetic flat closure or?
Yeah, so not all surgeons are able to perform the aesthetic flat closure. And because of what we talked about, the nuances with removing the tissue underneath the arms and then removing that tissue with is like a ridge of tissue underneath. The breast surgeons, we are trained to perform mastectomies. We both perform number of double mastectomies together and lumpectomies and other things that we feel comfortable in doing our own closures. But it may not be standard across the country where breast surgeons are closing their own incisions. In fact, like, I worked with one of the plastic breast surgeons in very famous breast surgeon in California who has plastic surgeons come in and close his incisions. So it's just different depending on, I think, your comfort, your time, and what other things are going on for you. So
But I even heard a patient went somewhere else for a second opinion, and they were going to have a lumpectomy, and they said that they were going to have plastics come in to close their
yeah,
incision, which I found a little bit odd as a surgeon. Hopefully, when knowing how to close our own incisions, I think if it's going to be challenging, it's nice to have a plastic
yeah,
surgeon potentially available. But I would think down the road if there'd be an issue. But it kind of depends where you're trained too. Sometimes the cancer surgeons only can deal with the cancer, and then they want the plastic surgeon to deal with that cosmetic issue. I think as a breast surgeon, that's why we did a fellowship, is that we're doing both the cancer and the cosmetic, and in our case, even some of the endocrine therapy for some of our
yeah.
patients.
So one more question. What drove you to be a breast surgeon out of all the things you could have done?
Dr. Haller, you
Yeah,
start?
yeah. So I actually wanted to be a trauma surgeon.
Mm.
So I went to medical school in Kansas City, and Wichita, Kansas, was my home. And I worked with trauma surgeons there who wanted me to come to Ohio to do my training in general surgery residency, which is 5 years, and then a fellowship, and then go back and help them be a trauma surgeon or be their partner. But then I came here. I met Dr. Cripe actually when I was a medical student, and then I worked with him a little bit. I had a young patient who was diagnosed with breast cancer. She inspired me, and then Dr. Cripe called me when I was a fourth-year resident, asked me, what do you want to do with your life? I knew I wanted a relationship with the patients, which you typically don't get with the general surgery or even with trauma surgery for sure. I like the intellectual stimulation with the research, ongoing research in the breast cancer world. and then Dr. Cripe being such an inspiration and a great role model. So those were all my reasons to go into to be a breast cancer surgeon. Also, I was diagnosed with breast cancer 8 months after I was already a breast surgeon. So I knew without a shadow of a doubt that this was my calling, and I have not looked back. And yeah, so that's my
I
story.
had to woo her. So she was thinking about
Yeah.
doing vascular surgery. I'm like, you don't want to do vascular. You want to
Yeah.
be a breast surgeon.
Yeah.
So it did take a little convincing too. My story started back when going to medical school. I thought it was going to be primary care because I love to talk to patients, or maybe orthopedics, just because there's an orthopedic surgeon in my church and I had some exposure to that. And then in medical school, when we're doing rotations, in general surgery rotation, it would be 12 hours. I'm like, oh my gosh, I didn't even know that the day was half over. This is great. And so I just fell in love with the surgical aspect of it and using my hands to try to fix things. My grandmother was an artist. And so I think that you're kind of putting your hands, surgery, and then for breast surgery, it's the ultimate, I call it body art, because you're trying to contour the chest wall or the breast so that you don't either see an incision or have minimal scars. So I came to do general surgery again, like you had mentioned, Dr. Harvey, here in Columbus, because we had a high volume center and we're doing lots of everything. I said, I want to see everything that I can. So when I get out, nothing's a surprise to me. And I really want to do vascular surgery when I came here. I love the attention to detail, but the patients aren't always the greatest. And the patients might be smokers, and then they just go home and they just keep smoking. Like, wait, I spent a lot of time doing a graft or trying to do a bypass, and they weren't as active in their health. And then I did 4 months of doing the breast and cancer surgery. The patients were more motivated to get better. They were bringing their family members, their sisters, their daughters in to say, how do I not get cancer? So it's almost like general surgery meets family practice. So you get to a bigger care model of taking care of a whole family potentially. They'll bring in their moms, they'll bring in their neighbors. And so it's really fun to get to know the person better. So
Yeah.
it really was kind of melding all of those things. And then ultimately, I think it's a calling. So I think God kind of said, okay, you're going to be gifted at doing this and talking to people and trying to be compassionate. And coming from a small rural town, I don't know that a lot of my family members understood what the doctor said. And I want to make sure that people understand, hopefully, what I'm saying. And so some of the handouts and the different things that we do to make sure that patients really understand as well as they can at that time their diagnosis and their treatment options. And so I just feel this is kind of my mission field, is to take care of people, because it's often the first time when you realize you're going to die. We all know we're going to die. We always say there's two things, right, that we know for sure: is death and taxes.
Yep.
But when you get cancer, it might be the first time that you realize, oh wait, no, I am going to die, and where am I going to go? And as a Christian, a number of people ask other questions for the first time in their life and be very receptive to that discussion, whereas before they might not. So I feel, again, it's my calling. This is where I'm supposed to be. So it's great.
Well, I'm thrilled.
Well, thank you. Thank you.
And he was my surgeon too. So yeah,
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 It's a tangled web,
it is
it is.
very much.
but it's great.
That's all I had.
Okay. Well, thank you so
Thank
much for your
you.
questions
Yeah.
today. And I hope our audience finds these questions to be valuable. And if you find this show to be useful, please leave a 5-star rating, if you will, and share it with other people. And also,
Don't wait.
don't wait.
So Jennifer Scannell, don't wait.
Jennifer Scannell.
That's great. Pick up her book, Amazon. Thanks everybody for joining.
Thank you so much.
Thank you.
Bye-bye. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvey.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.